Hello and welcome to my presentation. My name is Kevin Morris and this is about early mobilization in the post-operative patient and the benefits of that. I'll be reading my notes from this phone. So first we need to identify the problem. So my PCOT question is, in hospitalized patients that had a surgical procedure done, how does early mobilization compared to inactivity affect patient outcomes within their hospital stay? Lack of physical activity and prolonged bed rest have significant effects on musculoskeletal, cardiovascular, respiratory, integumentary, and cognitive symptoms, according to Dirks and Klazowski. This can complicate things during the postoperative patient's recovery time, making them more ill or have other post-op complications. According to Wong and Holloway, surgical site infections, also known as SSIs, is the second most common hospital-acquired infection, and a patient becomes more at risk the longer they stay. Delaying mobility will delay the discharge of the patient from the hospital. Implementation of early mobilization decreases length of stay, increases better patient outcomes, and decreases the chance of postoperative complications. If the patient stays in the hospital for a shorter period of time, they will have less of a chance to contract an infection, which will benefit the patient the most. And decreased length of stay also saves the hospital money. According to Souza Jr., Cruz, Nunes, Frailes, Filho, Oliveira, Bory, and Bouri, decreased hospital stays also benefit the hospital because longer time in hospitalization is associated to greater financial expenditures. So all around, the implementation of early mobilization will help everyone. Next, we need to assess the problem and identify possible barriers. First, patients may not be willing to participate in mobilization after surgery. They may be in too much pain, they could be nauseous, or they think that they were just going to be on bed rest after the surgery. Nurses may not have the time to help patients with their mobility. Nurses are very busy most days and may not have the chance to take the extra time to help mobilize the patient, or they prioritize the mobility very low. Nurses may not feel safe mobilizing patients so soon after the surgical procedure. Most of the time, nurses wait until physical therapy sees the patient and see what their recommendations are moving forward. Patients may have limited mobility depending on their surgical procedure. Most of the time, patients may not be able to ambulate or use other extremities to help them mobilize. Moving forward with assessing the problem, patients need to be informed of the early mobility plan before surgery. This will give a plan to the patient so they know what to expect after surgery. Proper non-pharmacological and pharmacological interventions need to be made to make the patient as comfortable as possible. Nurses need support from fellow staff members so they can implement early mobility. Nurses are very busy, but it's important to complete the task of early mobilization, so CNAs or other RNs need to be available to help. Nurses need to be trained on how to properly assess the patient's mobility level after surgery. Nurses should work with physical therapy to learn how to better assist the patient with mobilization. Proper equipment needs to be obtained to assist with mobilization in patients who are limited to movement. Wheelchairs, walkers, and other devices should be readily available in order to properly and safely help the patient. Next, we have the literature review. The first literature review explains an article with findings that implemented an enhanced recovery after surgery procedure, also known as ERAS, for intratrochanteric fracture patients. So after implementing the ERAS, the outcome was that the procedure was associated with shorter length of stay, lower postoperative VAS scores, reduced opioid consumption, earlier mobilization, significant improvement in the mean HHS, which is the Harris Hip score, scores at 3 months postoperatively, lower risk of complications, lower rates of readmission and reoperation, and higher likelihood of being discharged home. The next literature review acknowledges that the ERAS has many benefits for the patient and wants to determine if it's safe for the elderly population. So the article found that ERAS is safe for the elderly population and is beneficial, which can help shorten length of stay and decrease the risk of post-operative complications. Now we compare the current practice with evidence-based practice. So the current practice is we allow the patient to dominate care after their procedure. If they're sleepy, we let them sleep. If they're in pain, we empathize with them and give them pain medications and let them relax. We also wait until physical therapy sees the patient. We think physical therapy is the most qualified to be the first person to perform physical activity with the patient. Nurses low prioritize the early mobility for the patient. So if we wait for physical therapy to see the patient, they may not be seen for 1 or 2 days post-op, which would make things worse for the patient because they're not getting out of bed. Next, we look at evidence-based practice, so which points to ambulating the patient within the first 24 hours after their surgery. It leads to decrease in length of stay. We need to also set specific mobility goals to help improve overall patient function. We can achieve a better patient outcome by personalizing goals for each individual patient. ERAS helps increase better patient outcomes no matter what age. There is no age limitations on how early mobilization can benefit the patient. Now we look at the interventions. So we should explain the post-op plan to the patient before surgery. This will keep the patient informed of the plan and what to expect after surgery. Work with physical therapy to safely mobilize the patient. Physical therapy could have an in-service with the staff to go over safe practices. Physical therapy is also readily available in the hospital during their shift and could be consulted for tips while they're at the hospital. Evaluate the mobility level of the patient after surgery. The patient may not have the same functions as they did before surgery. Every patient needs a specific goal for them to meet based on their mobility level. Provide non-pharmacological and pharmacological interventions for the patient to provide a better outcome. Making the patient more comfortable will help them mobilize more. RNs, which is registered nurses, need to prioritize mobilization for the patient. If nurses have a patient going to surgery, they need to plan ahead and make time for when the patient gets back. RNs can work with CNAs, which is certified nursing assistants, or other RNs to help mobilize the patient. Teamwork makes the dream work. Continue to enforce early mobility and follow up with staff to ensure effectiveness. In order to keep this going, evaluation and encouragement is needed to keep the staff going. Now we evaluate the plan. So we need to ask, was the goal met with each postoperative patient? What barriers were met that prevented early mobilization? Were better patient outcomes achieved? Was length of stay decreased? Were postoperative complications avoided? Answering these questions can help determine if the interventions are working and where change needs to occur. Now, if you have any questions or comments, I can take that. And I can answer that for you. Otherwise, I hope you enjoyed my project, and I hope that you would consider implementing it at your hospitals as well. Thank you again for taking the time to watch my presentation.